Hello, my name is Maya Elliott, and I worked with Gracie Harrington to complete our substance use and unhoused populations presentation. So, the part that I will be focusing on is the epidemiology of the unhoused population when it comes to substance use. So, to first give some sources from the American Addiction Center, just in general, about the homeless population and substance use. It said, according to the National Coalition for the Homeless, substance use is more prevalent in people who are homeless than those who are not. In many instances, substance use is the result of the stress of homelessness rather than the other way around. Many people began using drugs or alcohol as a way of coping with their pressures of homelessness. I end up going into this a little more further down when I discuss the contributing factors. In 2020, the U.S. Department of Housing and Urban Development's annual homeless assessment report was given to Congress. And also in that report, it kind of brought up information from previous years. One specific year that is on this slide is that in 2013, 570,000 people who were homeless had a severe mental illness or a chronic substance use issue. To continue more with just some general information, according to the Substance Use and Mental Health Services Administration, or as we'll just continue to call them, SAMHSA, 38% of homeless people abused alcohol, while 26% abused other drugs. And then substance use is higher among homeless youth than among the general population. Later on, I talk about trends and the substance of choice between older homeless individuals and homeless youth are different. Okay, so when discussing trends over time, while I couldn't find very valid or reliable resources for if there was an increase in substance use over time between homeless individuals, I did find from studies by Coombs and et al. That substance use is more prevalent in males than females, and alcohol was the most popular substance used among the homeless population at the time of this study. Now, later, when I talk about other choice of substances, it seemed that throughout the research and throughout all of these studies, that there tends to be discrepancy between the most popular substance. It seems it depends on the location of where these studies take place. One of these studies took place in San Francisco, where they had mentioned alcohol being the most popular, and then another study took place in the Midwest, where and in the South, where they mentioned that methamphetamine was the most popular. So I'll be discussing quite a few um, substances of choice. So then after 2017, however, both alcohol and new psychoactive substances, or they were called NPS, were equally a problem. Like I said earlier, alcohol was reported to be the most popular, but even in that research, it had shown that there was already changes in that trend. Most research shows that currently 1/3 of homeless individuals struggle with substance use. And now we kind of get to the debate among researchers about the substance of choice for the homeless population. As mentioned in the previous slide, some research was stating that alcohol, but there was an increase in other psychoactives. Well, this study by Asaf et al. That was conducted this year, I believe in February, said that despite the focus on fentanyl and other opioids the past decade, methamphetamine use outpaced opioids among people experiencing homelessness at 33%. Now, also from a personal anecdote, a personal experience, the population I tend to work with is veterans at my practicum. Quite a few of the veterans I work with are homeless, and majority of them have a substance use issue, particularly with meth. Meth is the drug of choice for them. But alcohol was reported from numerous sources to be a close second, as I had mentioned in previous slides. Also, studies have shown that alcohol dependence is especially common in older homeless adults. And then, like I stated earlier, younger homeless individuals are more likely to misuse opioids, methamphetamine, or prescription medications. Although, from a personal experience with working with youth at my old practicum and at some old placements of mine, the drug fentanyl is starting to become increasingly popular among the youth. I noticed with older individuals when it came to fentanyl, it was usually mixed into other substances, and so they said they weren't really sure what they were taking. So when their test came back positive for fentanyl and they said that they were using meth, that was a pretty common occurrence. But when I worked with younger individuals, they would sometimes flat out say, yeah, I also use fentanyl. So now comes trying to answer the question, what are some contributing factors to this issue? Um, from numerous sources, there were numerous factors because, as we know, homelessness is not just an issue due to lack of housing. So, financial crises, family conflict, or mental health disorders can all precipitate homelessness. Um, in one study, there was mentioned that people who used substances before they were homeless had a higher chance of becoming homeless, but there was a good chunk of the homeless population that did not start using substances until they were homeless. So it also says that drug or alcohol dependence often evolves as both a cause and a consequence of living on the street, kind of just how I mentioned. Run reports indicate that trauma was a factor for 68% of men and 76% of women who were homeless and in treatment for substance use. Now, the key term for this is that this statistic came from people that were in treatment. There is not much known percentage wise of how much trauma became a contributing factor for those who have not seeked any type of treatment for their substance use and are a part of the homeless population. One part that I thought was interesting, so I obviously included, was that social acceptance and easy access to substances. So, without completely reading from this slide again, um, there was a report from the American Addiction Center that had mentioned that it was a lot more socially acceptable to use substances when you were homeless among the homeless population. Now, from the previous information that was gathered, we can infer that that's probably because of the high amount of substance use that is within the homeless population and how many people started substances when they became homeless in the first place, and how many used substances and as a result became homeless. It's easily accessible in homeless communities. Again, just from personal experience, some of the veterans I work with, like I mentioned, are homeless. They mentioned an ease of gaining access to substances even within certain homeless shelters. And then another contributing factor really is untreated mental illness. Um, there were studies that showed correlation between untreated mental illness and substance use. You have a higher chance of substance use if there's an untreated mental illness in a homeless person. Now, one contributing factor that I didn't mention on here, not only just for substance use, but also trying to find treatment, is the stigma around homeless populations and substance use in general. Specifically, I'll start with the homeless population. It is no secret that in America, there is a stigma against homeless individuals. And unfortunately, there have been news stories in the past of people harassing or attacking homeless individuals. And one article, I believe from the American Addiction Center and the Addiction Group, had mentioned that one of the causes that was inferred for meth use among the homeless population was to keep them hypervigilant against assaults from the general population, which I think fits into this contributing factor. And then the continued use of substances in a homeless individual because of the stigma not only against homeless people, but against substance use because it is um, difficult to accept treatment and for an inpatient substance use, outpatient substance use. There's stigma between getting any form of mental health to begin with, and then there also becomes the factor of the U.S. is heavily dependent on insurance. It's different if, say, you're a veteran and you're at the VA because that's different. But in general, if you don't have insurance or the insurance you have doesn't cover everything, then it's more than likely you won't get the services that you need in order to either reduce the amount of substances you use or just completely go abstinent and go into a full-fledged treatment facility. Um, but overall, there are many contributing factors to this issue, and Gracie will take over and begin talking about the prevention since I gave an overview of the epidemiology. Thank you.
Hey everybody, my name is Gracie Harrington and I'll be covering the prevention and treatment portion of this presentation. So, starting with prevention of substance use in unhoused populations. There's very little literature to support preventative approaches to substance use specifically for unhoused populations. Most unhoused individuals face compounded risk factors like trauma, mental illness, and poverty. So, by the time someone is identified for service, prevention is often too late. That's why many programs blur into early intervention or risk reduction rather than primary intervention. If a prevention approach for this population were to be created, it would likely focus on reducing the need to use substances in the first place by drawing from other existing approaches. So, what might this look like? The first is the integration of peer supports. Peer supports have been shown to be effective for helping people with many different needs, including both substance use and being unhoused. Peers with lived experience can help individuals to build healthy coping skills, navigate resources, and find alternatives to substance use. Having someone who has gone through the same thing as you and come out of it can be uplifting and may prevent individuals from turning to substances as a way to cope with stress. Next is targeting emotional and psychological risk factors. Unhoused individuals are more likely to experience chronic stress and mental illness. This also places them for higher risk of developing substance use disorder. By targeting emotional and psychological risk factors first, individuals may be able to reduce some of the stressors that could lead them to seeking out substances and reducing the possibility of substance use disorders developing. Of course, this is a multifaceted issue and cannot be targeted simply through counseling or therapy. Reducing the stressors of unhoused individuals would include targeting the issue of housing, food, security, safety, hygiene, and so much more, as well as the underlying mental illnesses that may be present. Next is reducing barriers. Low barrier access to basic needs that reduce daily stressors and promote stability are likely to decrease the need to cope with substances. So, this might include food, hygiene, shelter, healthcare, and much more. Additionally, having safe and secure housing has shown to be a protective factor for substance use within housed populations, as well as having access to food, healthcare, and hygiene. There have been many different treatment approaches for substance use within unhoused populations. The first treatment intervention I wanted to look at for this presentation was the integration of housing and treatment together. So, this looks like a combination of permanent or transitional housing with on site or closely coordinated addiction and mental health services. The most well known model for this is Housing First, but integration can take on many different forms, all of which usually integrate low barrier access, trauma informed care, and client agency as the foundations. The Housing First model specifically provides immediate low barrier housing without requiring abstinence, unlike traditional treatment programs that require sobriety as a precondition. Housing First is what the name suggests. It focuses on getting housing as the first step to overcoming homelessness and substance use. In many programs, substance use treatment is offered but not mandated, increasing engagement and taking some of the pressure off. Additionally, studies have shown that Interventions like this show improved housing retention, reductions in substance use, and improved mental health outcomes. The next intervention is harm reduction oriented treatment. Harm reduction is one of the most effective and humane frameworks for addressing substance use among people experiencing homelessness. Rather than demanding abstinence, harm reduction prioritizes safety, dignity, and survival. This treats substance use in a homeless population by meeting people where they are, by offering practical strategies to reduce the negative consequences of drug use without requiring abstinence. So, this can include things like providing medication assisted treatment to reduce drug dependence and injecting frequency, clean syringes and needle programs to reduce the chance of illness or infection, naloxone for overdose prevention, consumption sites to ensure a safe space to use substances, and access to safe sleeping spaces. Harm reduction builds trust and keeps people alive and engaged long enough to access healthcare, housing, and treatment if and when they're ready. Nowadays, a lot of harm reduction services are delivered in mobile clinics or through street outreach, which makes them really accessible to the unhoused populations. Additionally, harm reduction accepts that relapse is a part of the process and continues to support rather than removing people from services. So this is a really accepting and safe way to go about treating substance use. The next intervention I want to talk about is peer support. So, peer support helps treat substance use in unhoused populations by offering connection, trust, and understanding from people who have been through similar struggles or experiences. Peer workers, who are often in recovery themselves, can relate to the lived experiences of homelessness and addiction, which helps break down stigma and builds relationships that make individuals more likely to accept help and other interventions. So they can provide emotional support, share harm reduction strategies, assist with navigating services like housing or treatment, and they can model recovery as a real possibility. Additionally, because they meet people with empathy rather than judgment, peer supporters often reach individuals where traditional systems can't. The last intervention I want to talk about is contingency management. So, contingency management helps treat substance use in unhoused populations by using positive reinforcement like gift cards, vouchers, or basic necessities as rewards for meeting specific goals like negative drug tests, attending treatment appointments, taking medication as prescribed, or completing small recovery related goals like applying for housing. For people experiencing homelessness who often lack consistent sources of support or motivation, these tangible incentives can be a powerful tool to encourage healthy behavior and sustained engagement in care. Contingency management provides structure, immediate positive feedback, and a sense of accomplishment, which can help people build momentum towards recovery while addressing urgent needs. Because people experiencing homelessness often face extreme scarcity, like their basic needs being unmet, high levels of stress and trauma, and few immediate positive reinforcements other than drugs for healthy behaviors, contingency management helps bridge that gap by offering immediate, consistent, and meaningful rewards, which can compete or often replace the short term reward cycle of substance abuse. Conventional substance use treatment has been adapted for unhoused populations by becoming more flexible, accessible, and trauma informed, by recognizing the unique barriers that unhoused individuals face, like using drugs in unsafe, unsanitary, or even public spaces, being more at risk to experience non fatal and fatal overdoses, having limited access to sterile supplies, treatment, or overdose reversal tools, and also having to face criminalization, stigma, and healthcare discrimination. By having more flexible and accessible and trauma informed interventions, providers and communities are able to better serve unhoused populations.